Welcome to day 4 of the Putting Pieces Together conference, a conference for and by people living with pain. We've had so far 3 exhilarating and powerful days, and we're now at our 4th and final day. I just can't even believe it. For those of you who don't know who I am, my name is Jennifer Daly-Cyr, and I have the privilege to acknowledge that since I am in Ottawa, I am on the traditional unceded territory of the Anishinaabe Nation. I'm so grateful to be here as one of the steering committee members for putting the pieces together, a conference for and by people with pain. For those, my journey began with a sudden onset of abdominal pain about 8 years ago, and I've since been on a journey of learning to live with chronic pain and adapting to the dramatic changes this has brought really to daily life. And in my case, despite numerous and ongoing investigations, I have not yet received a diagnosis. I continue to deal with persistent debilitating pain episodes for the moment. But I want to say that the gift in this unexpected twist in my life is that it has found me here today as an advocate for the vital, a person with lived experience lens in chronic pain health initiatives and scientific research. It's a privilege. So enough about me, because you're all waiting, I know, to hear the panelists for today. We have 2 sessions today, each for about an hour. The first session will be about the state of pain in Canada, during which we will be hearing perspectives from 5 people. Former Canadian Pain Task Force members, Maria Hudspith and Linda Wilhelm. We have from Health Canada, Jean-Francois Leroux and Jennifer Novak, and Pain Canada National Advisory Committee member, Keith Meldrum. A wonderful opportunity for an incredible constructive dialogue. Between the 2 sessions, there will be a 1-hour break, and then a podcast hosted by Sick Boys podcast hosts Jeremy Sanders and Taylor McGillivray. And they'll be featuring guests Natasha Turanan and Virginia McIntyre. During the 1-hour break, however, we invite you to participate in a couple of things. There'll be a gentle movement session led by Neil Pearson, who is a physiotherapist. He'll run a 30-minute session and show differing levels of movement for all abilities. And for those interested in a full hour of peer discussion, there will be breakout rooms, one with a pre-assigned discussion topic of pain and relationships, and the other simply open to talk about whatever you wish to speak of. There will be 2 Pain BC support service staff in the general water cooler session, and they'll be available to connect. Each of the sessions has a chat to the right side of the video stream in Feedloop. If people are joining in Zoom to participate, you can use the Q&A function. These chat and Q&A functions are being monitored so that this session is live. All questions will be shared with the presenters through the 2 functions. As I mentioned earlier, closed captioning is available to viewers who wish to join the Zoom session, and as well there will be simultaneous French translation. To turn on the closed captioning, you simply turn it on by selecting the CC button at the bottom of your screen as a viewer. You can then select the language you would prefer to see these captions appear in. Please remember that this conference has been designed for and by people with lived experience. We've done our absolute best to design it to create a brave and safe place for people who live with pain. And while everyone is welcome to attend, including researchers and clinicians who are here to learn also, we hope that you spend the time in the water coolers listening to the experiences and perspectives of people living with pain, rather than having these spaces utilized for research or other purposes. A huge thanks to the conference sponsors, Pain BC, the Strategy for Patient-Oriented Research Chronic Pain Network, and the Canadian Institute of Health Research Institute, Musculoskeletal Health and Arthritis, and the Partnership of Engagement of Patients with Pain Research Projects. With that, it is my sincere pleasure to introduce our panelists for today. The panel discussion is going to be about what are we doing about pain in Canada today. Feel free to use the bios on the website to visit a little bit more about who they are. But for now, I would like to introduce, beginning with Maria Hudspith from Pain Canada. I'd also like to introduce Linda Wilhelm, a former Canadian Pain Task Force member. Jennifer Novak from Health Canada. Jean-Francois Leroux from Health Canada. And last but not least, Pain Canada National Advisory Committee member, Keith Meldrum. Over to you, panelists, for this wonderful and constructive discussion that I'm so looking forward to.
I think Linda was going to start us off. Is that what we're still with that plan?
Sure, I can take over and start us off. Welcome everybody, and I'm just maybe going to share a little bit about my personal journey, and then I'll turn it over to, I think Maria is next after me. Is that correct? Or who's after me?
I think Keith. I'm going to go last.
Okay, good. All right. So in 1998 and 1999, I spent the better part of those 2 years in a wheelchair, ending 1999 with 3 months in the hospital. After 16 years of living with uncontrolled rheumatoid arthritis, and I needed a new medication that was not available in Canada yet. I had tried to get special access to it and was told repeatedly that I couldn't get access. It left me with chronic pain for the remainder of my life. I ended up getting access to that medication after 3 months in hospital and walked out of the hospital within a couple of weeks, but spent the next 6 years having surgeries every 6 months to repair a lot of the damage, and was left with only 2 joints in my body that were not affected by my arthritis. I think, like most people, I thought that the government and the healthcare system and everybody knew what they were doing, and that, you know, they didn't really need me to tell them anything. And I think I quickly learned that that wasn't the case. So it spurred me to become involved in advocacy, and say once the medication was approved by Health Canada 2 years later, I decided I needed to start speaking up and finding out. And the internet connected us. I ended up reaching out, and the internet was, you know, had just started to become accessible to many of us at that time. A few people had it, but, you know, it wasn't really widely available yet. But we connected online, and I realized that there were other people out there that were experiencing the same thing I was experiencing, and it surprised me. So we started pushing, and, you know, we knew that these drugs were expensive and we had to try to get coverage. So we pushed and we met with governments, and some of us, you know, were not in great physical shape. We were living with pain. We had, you know, these were people pre-biologics that had all, like me, you know, had gone years without having effective treatments and were quite disabled through our disease, but we knew we had to stand up. So we started meeting with governments, provincial, federal governments, and, you know, eventually by 2003, the drugs were listed on every province. At that time, the government, Health Canada, started their modernization of the drug review system, and so, you know, we got involved in some of the consultations. It was one of the first consultations I ever went to, and I'm not sure, I think it was 2004 or 2005. And it was quite new, and there was only 2 patients at this consultation of about 150 people, 2 patients in the room. And I was, it was very intimidating. You can just imagine the power imbalance, all the government officials, all the researchers, all the clinicians, and the other patient that was there, she left, and I was there by myself. And one of the Health Canada reviewers started talking about the review of the special access program. And that was a program I had tried to access through special access, to get the biologic that I needed so badly. And, it was, again, the soft skills had to come in. I was trying, you want to be respectful and you wanted to be productive. But I just, for me, my heart beating out of my chest, he's going on about, special access program is designed for, life-threatening serious diseases like cancer and HIV. And I had been involved in the arthritis community with an organization called ACRU, which is the Arthritis Community Research Evaluation Unit. And they had just published Arthritis in Canada, partnering with Health Canada on this publication, which actually showed that there were more people in Canada dying from arthritis than HIV, because HIV people were getting their medications and we weren't. And so he went on about how serious, special access is only for serious disease. I said, I live with rheumatoid arthritis. I don't think you realize, like, this time, I'd say I was the only patient in the room, and I was very respectful, but I said, there's more, we just published something with Health Canada, and it's actually, the evidence is showing that more people are dying from arthritis than HIV right now. And you could have heard a pin drop in the room. And that just spurred on. And from then, we just kept getting involved. I remember going to standing committees on health and, with politicians, and I won't mention names, but, actually being called out that, how could we expect government to pay for these expensive medications, and, and different, just kind of challenging us on, our positions. And as a patient going into this intimidating Parliament Hill, trying to, make change and trying to make people understand that, how we needed to have that voice of people of lived experience at the table. And this was all so new and scary to those of us that were doing this. And just being so grateful for those opportunities to be able to do that, and to see, now 20 years later, we see that we had, the opioid crisis, which kind of affected so many of us living with chronic pain and our access to medications, and then get invited to the opiate symposium and having the round table with the minister, my organization, CAPA. We did the survey to talk to people with pain to find out what their experiences were, that we presented to the minister that day, and had this amazing conversation with the minister. And I know JF was there as well, and just how he helped facilitate and to see this change, just embracing of people with lived experience at the table. And then shortly after the task force announcement, then the action plan, and these things that have all happened that we think, oh, it's so much to do, and this, we don't do enough. But to look back and see the evolution of how far we've actually come, and then to have the minister this week, again at our meetings, and to see how all this is going to impact people living with chronic pain. And I think I'll end there.
That's amazing, Linda. Thank you for sharing that, and your experience and the challenges you faced and what you've done with that. It's amazing. Keith, would you like to share your perspective?
Certainly, thank you, and thank you for that, Linda. It's a very powerful story, so thank you for sharing that. I would like to just take a moment as well and share a little bit of my story as my journey into pain. And I staggeringly hate that term, journey into pain, but I don't know how else to capture it. But I think it will help frame where I see things are going now, and where we're at. So like so many, 1 in 5 million in Canada, I'm a person who lives with pain. I personally think the number is probably higher, but we'll let the statisticians fight that out. But my introduction was just over 36 years ago, when as a young and dumb and invincible 16-year-old, I was absolutely convinced that I could get behind the wheel of my car after drinking most of the night and getting no sleep, and that I wouldn't fall asleep and pitch my car down a bank and roll it end over end. So I discovered rather quickly that at 16 or any age, you're not invincible. And that left me with significant traumatic abdominal injuries that were nearly fatal. And I was very, very fortunate to have my car accident witnessed because it was on a rural, remote highway. Otherwise, I wouldn't have the honor of being able to speak to you lovely people today. But that was the beginning in August of 1986 into what ultimately led to a life living with pain. You know, despite after the initial surgery and times in these ICUs and multiple follow-up surgeries, I had surgeons that were very focused on fixing all of the trauma within me, but underlying all of this, I kept having pain. And I'm young and kind of dumb, and I didn't think that pain could exist, because in my little brain, it was still forming. When you have an injury and once it's been fixed by the medical profession, then your pain goes away. This is a little kid, I broke everything, broke my nose and my arm and all that. And when they fixed it, I was all better and I could go out and play again. I couldn't play because it hurt all the time. And I think one of the most telling interactions as to where we were then in the late 80s to where we're at now was when I was standing in my then family physician's office, about 2.5 or maybe 3 years post-car accident. I'm about 5 surgeries in. I'm having this ongoing underlying pain. And he looks at me with all the compassion that comes from a rock. And he says, the surgeons have fixed everything that they can. This is all in your head. So 19 years old now, and I'm just floored with that, because now I'm struggling with, why does it hurt, but am I making all this up? Is it in my head? And if I am making it up, what's wrong with me? Why would I want to do this to myself? Why would I keep going into the hospital? Why would I have pain if it's not real? And it caused so much confusion, but I still had this ongoing, unrelenting pain that would keep putting me in the hospital because I was young. And then after he made that statement, I was absolutely convinced that I was going to show everybody that I was fine, because I couldn't get anybody to talk to me about what pain was. Because in the late 80s, I would offer it was only viewed through that lens of, a biomechanical lens. So I had injuries that had been repaired. They did the best they could. So there was nothing more they could do to me. And there was no consideration about the totality of people's impacts with persistent pain. And Linda's story is moving. It affects her entire life. 2 joints in her body that's not affected. It affects the entire person, not only physically, but emotionally, psychologically, spiritually, your family, all of these things at the time, which weren't considered. And I know I didn't know how it informed my pain. So my way of dealing with it was to just push through and make staggeringly bad decisions to show everybody and myself how that I didn't have pain. And all I kept doing was putting myself in the hospital and just creating all sorts of nightmares. So for about 18 years, I consider myself having lurched and stumbled through a medical system that was staggeringly ill prepared to deal with somebody that lived with underlying severe chronic pain, because all you would do is you would push yourself, have breakthrough pain, wait till it was too late, drag yourself into the ER knowing it was going to be the worst experience on your life. It's a bit hyperbolic, but it was not going to be a very positive experience. Spend hours on a bed until somebody said, I guess we can give you something for pain. And then they either kicked you out or kept you for a while. But that whole ER interaction was, really, is it that bad? Are you sure? Why are you here? It can't be that bad. I've looked at your chart. Everything's fine. You're not a human being. You're a person in a chart and a collection of symptoms that they read and they say everything should be fine. So as I continued to work through that and was passed from doctor to doctor, because I kept looking for the solution, that true panacea. I just needed the right doctor to fix me. And I was just sure they weren't trying hard enough. But still in the back of my mind all along was my family doctor saying to me it was all in my head. So it was this really dual path that I was walking at the time. And it wasn't until I had an interaction with a healthcare provider, going through I was recommended for, with actually spinal cord stimulation. This was in 2004. I figured I'll give it a shot. Nothing else was working. And I bookend this with my family doctor in the late 80s saying, there's nothing wrong with you and it's all in your head. And the change that occurred when this doctor looked at me as we're doing the intake, and he puts his pen down and he stops talking, and I'm ready for him to tell me there's nothing we can do for you. You're not a candidate. It's not that bad. And he simply said, it's okay, we believe you. And that point of validation was the turning point for me. It allowed me, not overnight, because I'm a bit stubborn and slow to learn, but it allowed me to change my trajectory of one of anger, grief, I would offer, and fighting through it, to start to learn to live better with pain. But even in the early 2000s, there wasn't a whole lot of support. To this day, I've never had anybody talk to me or teach me about what supported self-management is, what I could do for myself. I had to learn that all on my own. But once I started down that path, that was my impetus, like Linda, to start to want to share my experiences, because it hadn't been very good for 18 years. And once I had my pain validated, and I no longer believed I was making all of this up and that it was real, and then I started to understand this complex relationship between our lives and our pain, I was able to start to do things to better help myself. And I offer that because fast forward now to 2022, and now we're knocking on the door 2023, the things that I wasn't taught, I wasn't shown, that anybody that would listen to me, I would talk to, and Maria and I have had some experiences where we've had an opportunity to talk to people. And I remember years ago saying I couldn't get 5 people in a room to talk about this, and now we have a nation talking about it. We are seeing healthcare systems and healthcare providers starting to understand the depth and the complexity of persistent pain and how it is a whole person issue. It's, I would offer, not yet well coordinated. It's still a bit ad hoc. It's a lot of individuals or small systems trying to do things. But the fact is, in my 36 years, I have seen a transition from there's nothing wrong with you and they exit you from the healthcare system, to people starting to talk to you about, this is a complex issue and there are things that we can do to help you. And some of the changes that I'm seeing, even though there are days where I still get very anxious that it's not happening fast enough, we have come a long way. So we're seeing healthcare system change. As a person living with persistent pain, I'm seeing my individual experience and myself as a human being, not a person with pain, but as a human being that can contribute, is changing. I've had the honor now to co-author 2 papers that have currently been researched on sort of the depths and the complexity of pain. And I was treated as a full subject matter expert with all the PhDs in the room, and not the box that was checked to say must have patient partner or anything like that. So I'm really excited to see the change that is happening. This week is a staggering example of it. The announcement from the federal government made me fall out of my chair and hurt myself a little more, but it was worth it. But we are seeing the change that is happening, but we can't take our foot off the gas. This truly is a turning point. And I go back to the conversation I had with Maria years ago when I said we couldn't get 5 people in a room to talk about this. And we now have the nation's ear that is listening to us. So I am, like Linda, this has been a challenging experience. And like Jennifer said, but if it wasn't for this, I wouldn't have this opportunity to have met the amazing people that I have and to be involved in some of the things that we're doing. So I'm excited. I'm buoyed by the changes that are happening. I want to see more happen, and I believe that framework has been set to be able to move forward. And the one thing that I would offer is through all the things that we're doing, I would ask every politician, every healthcare system, every bureaucrat, every administrator, every clinician to never, ever forget that you're dealing with a human being in front of you, not a person that is a medical case, but a human being with fears and emotions and hopes and dreams that happens to have a disease called chronic pain, and they're just looking to live the best life they can. So I think we've come a long way. I'm really excited. I'm honored to be here today, but would love to see this trajectory continue forward.
Keith, thank you for sharing your powerful story. I have to say, I'm getting a lot of goosebumps listening to your story, listening to Linda's, and the powerful examples you've both presented in terms of the voice of a person with lived experience and the impact that can have over time, and how you've demonstrated how you've been a part of that timeline, the evolution. and the importance of viewing biopsychosocial as the whole person. And so thank you very much. I also meant to mention earlier, for those, I see that there are questions and comments coming in. I do want you to know that they will be addressed. We just first want to give our panelists a chance to have an opportunity to say what they're planning to say today. So just so you know. So I believe Jennifer, did you want to, you're ready to go next?
I don't know how you want me to follow. I'm like the boring part of you can all put your like mute on and wait till it gets to Maria, I guess at this point. But hi everyone. I'm Jennifer Novak. I'm from Health Canada, and really pleased to be here today. I'm coming to you from Val-des-Monts, Quebec, the unceded and unsurrendered territories of the Algonquin Anishinaabe people, and it couldn't be more pleased to have been invited to this today. I think both Keith and Linda, have been at this for a few decades. I've been at this for a mere 4 years, but I too am kind of happy to see the progress that has happened in that short period. I started on the team. We were looking at like, well, who are we going to put on this infamous Canadian Pain Task Force? How do we build this thing? And our principles at the time, really coming out of the symposium, was how do we put the voices and the needs of people with lived experience with pain at the forefront of our actions, and how do we take that into consideration and in mind as we move forward on a Canadian Pain Task Force, and really have that kind of holistic, comprehensive, pick the most inclusionary word you can to build that team. And I think the principle, kind of how Linda and Keith have brought it up, is that we were never meant to do this alone. May have been alone for a few periods, and Keith and Linda have explained how much they had to advocate for themselves, but we were never meant to do it alone. We were always meant to do it together, hand in hand, and where my shortcomings come, hopefully somebody else can compensate for that somewhere else. And so, for us, as we kind of sunsetted the task force, because we have these kind of great recommendations, we're really looking towards the future, and hitting a year since we've kind of transitioned out of recommendation mode into action mode. I'm happy to say that we do have some to report. I promise you we do. And one of them is really kind of creating a permanent fixture within Health Canada through a chronic pain policy team with JF and I here today. And I think, to Linda's point about, the special access program, to the comment in the chat about how do we get drugs in Canada, federal government, it's like this big, monolith of no human person to connect with. And I think the whole point of having a chronic pain policy team is you have a human, you have a name, you have a person you can call, and that's JF and I. And we'll do the legwork of finding who that right human is for you, whether that's a Health Canada person or someone else in government. And sometimes it's not even someone in government. I'm sure some of you have actually written to us, so I'm. If you need to write back, JF and I will talk to you, and we'll respond if what we provided was kind of insufficient to address your needs. But we recognize at the federal level that we're not the one doing the service delivery, but we sure as heck can help with what I call the WD-40 grease in the wheels kind of thing. So I won't get you a doctor necessarily, but I can probably find you some organizations or some services or different things that we can kind of help direct you to. And that's what we're trying to do. JF and the team and I is become navigation specialists, if we can call it that. And so Keith and Linda and others have mentioned on Monday the minister announcing investments into Pain Canada. And that's a complete direct outcome of recommendations coming out of the Canadian Pain Task Force, but also from JF and I. Sometimes you have to write the proposals in the right way and get it to the right person at the right time. And you have to even know that there's a place where you can go and hey, did you know there's a call for proposal right now where there's money available? And that's what we're trying to do. Pain Canada will be that beautiful kind of focal central point for Canadians, for researchers, for health professionals, that kind of one-stop shop. We're trying to do that as well at the federal level, but in a different capacity, in a different way. But we recognize that there's more that can be done. And so we do have, a grants and contribution program. We actually have 17 pain projects since 2018 that have been funded. And again, it's about making those connections so that these services in smaller communities, national, scale projects can actually get that seed funding to kind of get them going and get them off and on their way. And so, we understand that the need for pain to kind of be better considered by, frankly, all levels of government across the country, and really looking to address those priorities. And I've said in other forums, there's never always going to be this one, pocket of money called Solve Pain in Canada. There's just a whole bunch of pots of money at different places at different times. But what I can tell you, especially from the work that JF and I have been doing, is that pain is this common thread throughout every single health priority. I was listening in at the health ministers' meetings even earlier this week, and we were talking about stigma. And at the time, the conversation was about mental health and substance use stigma. And Minister Bennett, over the course of the last year, being exposed to Linda and Maria and talking with stakeholders and, having, briefings from little old JF and I, she said, and pain. There's still stigma about pain too. Let's not forget that one. And even that I see as a shift and an improvement, because it's being added to the thought. It's not an afterthought. It's always top of mind. And I think that's the important part of having these conversations to the point made. We're not there yet. Lots of work to keep doing, but we're top of mind now. And that's where we want to be. That's where we want to be. And so, there's been, many unintended consequences over the years of, federal actions, provincial actions, and I want to recognize that. But there's also a path forward to fixing and amending those pieces. And I want people to understand that the advocacy is what gets that done. That's the important part. We need you, our collective, none of us doing this alone, kind of all coming together to get the change that we frankly need for this country. So don't want to take up more time, but with that, maybe over to you, Maria.
Before I say anything more, JF, do you want to weigh in on the work that your team is doing? And you've been so central from that early meeting, the roundtable with the minister, to the creation of the task force, and then you left us and you came back. But do you want to share anything about the work of your team?
Well, I think Jen kind of really gave it a good overview. What I would add is that I think for many years and even today, I think there is a need to bring further awareness about the importance of chronic pain federally, amongst our federal colleagues, understanding how much connections there is between chronic pain and some of their policies that they are implementing, whether it is policies within the health portfolio around primary care, around health human resources and addressing the crisis, around mental health, around all those different policies. But then there is also other federal departments like Employment and Social Development Canada that are implementing some great policies around employment strategies for people living with disabilities, for instance, so that they don't forget that many people living with pain should be considered as these types of policies are being implemented. So really our team is trying to bring those perspective and making sure that they don't forget about pain as things are actually being progressed. So this is kind of like one of the key function of the team. And as Jen mentioned, obviously the connections with all of you people living with pain, key pain organization, members of the Pain Canada National Advisory Committee, and making sure that they are being engaged as we kind of like push those policies forward. This is kind of like central to the work of our team. But yeah, that's just what I would add for now.
You know, this week has given, I think, many of us just pause seeing the announcement from the minister, seeing, you know, this has been the biggest reach with National Pain Awareness Week. By day 3, I think we were at 3 million in the reach of that campaign, which really has blown last year out of the water. And that's really because we're harnessing the power of the collective. You know, last year we had 500 organizations and individuals, everybody from Mom Stop the Harm, you know, grassroots, parents who have lost their kids to overdose, to groups like, you know, the Nurses Association, the chiropractors, to groups like the Canadian Building Trades Unions, which represent 500,000 construction workers. And to see people embrace this campaign and see the relevance of it for their own missions, their own priorities, that's just been incredible. Every time I see Keith Meldrum or hear his voice, I think about this day. I think it was like 2012. And I got this email from this person saying, I'm somebody living with pain. I've just been, you know, heard about your organization and I want to get involved. And we started going back and forth, and, you know, Keith ended up joining our board, being the chair of our governance committee, being the vice chair of our board of directors. And eventually, you know, we had to kick him off because he hit his term limit. But I think, you know, so many people with lived experience who have been at the table finding their voice. I mean, I don't know if even that's the right word, but getting engaged and going from, as Keith said, you know, not being able to get 5 people in a room to hear their stories or care, to now seeing a national action plan in Canada, seeing the minister's Twitter feed, you know, all day Monday, pain, pain, pain. And just seeing the momentum that this is building, this movement that's being created. You know, for me, it's so akin to other movements that we've seen, whether that's HIV, the work of people who live with mental health and substance use, to say nothing about us without us, that the clarion call of the disability justice movement. And I think now is the time. You know, it's a time for pain. It's really an issue whose time has come. There's so much more work to do. I know through my own involvement, like we've really seen the limitations of some of our engagement. So while we've had more and more people coming to the table, we've seen that those voices really represent some particular perspectives. We are trying to do so much more to engage racialized people, young people, Indigenous peoples, newcomers and refugees, men who often, you know, are not wanting to acknowledge living with pain, people who are not only struggling with pain, they're struggling with poverty, mental health, substance use, stigma, and people who are living with in poverty. You know, pain, we say pain doesn't discriminate, but we know that there are populations of people who are disproportionately affected, and because of systemic barriers and challenges, have additional barriers to getting help, to being seen, and to not having their interactions with the healthcare system further marginalize and traumatize them. So I'm really hopeful. I think sometimes we can revel in the successes. We also really need to look at what else needs to be done, who needs to be at the table. We need to challenge ourselves. I was listening to the session yesterday with, very beloved colleagues from across the border who were talking so much about the work that they've done to integrate the chronic illness, chronic pain, and disability justice communities. That work is just beginning in Canada. Those sessions, if you didn't hear them, just mind-blowing. I really encourage you to watch the recordings, and we have a lot to learn. We have a lot to learn from those folks in the US, even though they look at us and think we're further ahead in some ways. We are, but they have a lot to teach us. So I'm really excited for the future. The fact that we have, I think of Linda and Keith and others as sort of the veterans of this movement, and then to see so many folks coming to the table, like the steering committee for this conference, who brought some really fresh perspectives, like the comedy piece, and even just the thinking about this theme, this metaphor of kintsugi, which I think has resonated at such a deep level for so many people as they've participated over these last number of days. So, I did this interview yesterday on The Current and on CBC, and the host said, should people be hopeful? Should people be optimistic? And I was with a very cherished colleague, Norm Buckley, and he said, people should be cautiously optimistic. And I think I feel the same. Just like Keith said, we cannot take our foot off the gas pedal. We need to be pushing this forward. Some of us need to get out of the way and really support and amplify the voices of diverse communities and make sure we're attending to the needs of all people who live with pain. So I'm hopeful. Healthy skepticism is always there, but just really, really grateful for the people inside government, the people outside of government. We need everybody. We need the people in the streets. We need the people in the corridors of power. And hopefully Pain Canada is going to be a bit of bridging for that, knowing that change happens in lots of different ways. And the ways that we think about change, there are people that look at the Canadian Pain Task Force and they say, that's BS, pardon my language. They look at that and they think, that's not real. They want to be in the streets, and that needs to happen. There are people who see the task force and they think, that's how the change is really made. It's all of it. Jennifer and I talk a lot about this top-down, bottom-up synergy, and that is really where the magic happens from my point of view. So just it's always an honor to work with so many of you and to have supported the vision of people that wanted this conference to happen. I'll stop there, and Jennifer, turn it back to you.
Thank you. And you absolutely unwaveringly supported this conference, and the steering committee appreciates it greatly. And I just it struck me during this, listening to these unbelievable perspectives here today around the one common word that I heard in addition to pain was collective, our collective viewpoints, and sincerely appreciate hearing all the work that's happening through Health Canada, through Pain Canada, and how this is all tied into the task force work. I mean, it's just, if we were to draw a diagram, we would see how all these connections are happening. And it's so encouraging to hear that, while a few of you have mentioned that we're not there yet, but we're certainly on our way. And that's, to me, as an individual, gives me great hope. We have a number of comments and questions that have come in. So let me just begin with what I'll do my very best to cover all of them. If for some reason we can't, we'll address them in following the session, but we'll do our level best. I'll start with one question that came in asking, how can people get involved to support Pain Canada? Are there different ways that we can help, either as a volunteer or fundraising initiatives?
Yes. Absolutely. So I would say just send us an email, go to the Pain Canada website, available in both French and English, and just fill out the contact us form, get on our list, send us an email to info@paincanada.ca. And we are going to have in the new year and later this fall, so many more opportunities opening up. So please reach out and get connected.
Great. Doesn't get much better than that. Something came in also, and I believe it's been partially answered, but I do want to make sure that you have an opportunity to add comment if you wish. The individual indicates that they have an intrathecal pump, which contains hydromorphone to control pain from chronic pancreatitis, pardon me. And this device has been invaluable, allowing me to resume many activities I could not previously do with pain. This device is not currently approved in Canada, only plasticity. I received my first pump in Boston and brought it back into Canada so that I'm able to have it refilled. Is there a reason why I can't have access to this technology in Canada, as it is clearly a superior technology in this individual's opinion? So
I'm happy to take that question. So the great thing and the sad thing with medical device technology, it is one that moves at a speed of lightning. And so in order for it to be marketable in Canada, the company needs to feel like there are enough Canadians here that would be willing and able to pay for it in order for them to decide to bring it to Canada. Once they make that decision, then they come to Health Canada with an application and say, all right, we've done some kind of market research and we want to come to the market. Can you give us a license in order to do so? So we at Health Canada are kind of we just wait for people to come to us with those applications. And so to the earlier point about advocacy, it's important that those companies know that there is a market. Canada, although we think that we're pretty big with 38 million Canadians, we are really, really small in the grand scheme of things. And so as a regulator for drugs and devices, we're like really far down the food chain when either pharmaceutical companies or medical device companies choose to market in our country. They'll go to the European Union because they get a bigger access to multiple countries at once with one application. US has obviously a much bigger market, and Asia is in the same way. And so Canada always kind of drags behind because the market size is just not what companies think may be profitable. However, if there's enough advocacy that goes to the company, they will come through. But to Linda's point about her biologics, the special access program that exists for drugs also exists for devices. And so there are ways to see if one product is more beneficial for your use given your specific needs. And I think it's that kind of precision medicine, that kind of really identifying the right product for the right person at the right time. We're moving towards that. The regulatory system is just not one that is very nimble. And so we work around it in these exceptions, and the special access program is exactly that. It's the exception way. But there's the advocacy with the company to get them to come here. There's the working with your physician to get it through a special access program. If you found a device that is helpful and you need, different parts or different things for it, that is in the realm of the feasible. And obviously JF and I can kind of help direct you to the right places for the medical device kind of special access program if that is something that could work for you. But that's the reason why it doesn't why we're always behind. Companies don't feel like we're a large enough market to start with us. That's really the main reason we see it. Yeah.
Fascinating insight. Thank you
I'm
very
going to
much,
jump
Jennifer.
in, Jen, as well here, because
Mhm.
beyond Health Canada, because they always get blamed for everything, there's also another process, the Canadian Agency for Drugs and Technologies in Health. So once it gets through Health Canada, it also has to go through CADIT, and then after CADIT, it has to go through the provinces. So the processes in this country are very complex. They're very hard to navigate for patients. I would encourage everybody to advocate for CADIT. They have a patient input process. They have a patient engagement team, but they need to hear from more Canadians about people wanting to have their voices heard at those tables, because they really have improved those processes much beyond 2010.
Fabulous. Thank you for that insight, Linda.
And
I'd like to
Jen,
share a few comments that were posted as well along during the discussion. There was one comment was, so many of us were victimized by the fentanyl, in brackets, not opioid crisis. So just an important point there. That validation is a turning point for patients, and that was certainly mentioned. Keith, you specifically mentioned that. In addition, we hear that doctors also look for disease. When my daughter was finally diagnosed with myofascial pain, once the doctor said, "Oh yes, I can see you're in pain," we both cried. The validation was everything in that moment. And I would add, to be understood, our lived experience is not to be dismissed or discounted. Such a great points. Thank you. I have another question. There seems to be very few pain programs in Canada that use art and
Sorry, Jen.
creativity for pain management and solution. Oh, pardon me.
Sorry, Jen, I just wanted to jump
Yeah.
in on the,
Yes.
the fentanyl crisis. Obviously, that's
Yes.
the kind of other side of my job. And having been on this file now for, oh gosh, nine years in different parts of Health Canada, what I can say is there wasn't a lot of data, okay? When we were starting to see high rates of overdose deaths, there were about 2,000 people dying about every single day from OxyContin overdoses, 2004 all the way up to 2015, 2016. And so the data that we had at the time and what we understood to be the case was that this was a prescription issue. But the drug market changed. The illegal drug market changed. And like any good economy, organized crime changed. And when they saw that there was a market for prescription OxyContin and oxycodone, they started providing that to Canadians as a market. And that led to, as you noted, fentanyl really kind of coming into the market. The spike, though, that we've seen in the last, 5 or 6 years is one from that illicit market. For sure, it's 100%, no, it's not 100%, I can't say it. I think it's like 90% of overdose deaths are with fentanyl. The challenge that we had, though, in 2015 is our data, we were looking at stuff from 2004. And this is a conversation we have a lot about research and surveillance and data and real-time data. And I look at the COVID pandemic and I'm like, how can I get like real-time, like yesterday's numbers on pain issues or on substance use issues? If you could do it for COVID, can't we do it for other things? And that's the advocacy that we need too, about the importance of balancing having good data to make good decisions, because those unintended consequences that we've all experienced in the years based on outdated data. And so we made all of these, changes, and colleges wanting to do the right thing, all clamped down, and people were tapered unnecessarily or removed from their opioids altogether, which had dire consequences across the board.
Mm-hmm.
The intentions were good, the results were not, though. And people's lives were lost because of it.
Mm-hmm.
But it starts from if you don't understand the problem you're trying to solve, you don't solve the right problem. And it starts with data. And so I think it's so important to recognize the harms that were done by some of our practices and policies. But part of that is, how do we learn from that and make those changes? And it is about making sure that we have the right data at the right time to make the right policy and program decisions.
Fabulous. The all important data for sure.
Mhm.
And thank you for that wonderful explanation. If I could just, if we could, there is a question on, there seems to be very few programs in Canada that use art and creativity for pain management and social education. So many other countries have well-developed interventions in arts and health and are prescribing arts to improve social, physical, brain, and emotional health for chronic pain patients. Why is Canada not capitalizing on this evidence-based intervention? So a question around data in a sense. Who would like to answer that question? There.
I can certainly take a stab at it. I think these are some of the questions, when we think about, Linda, Keith, many of us who've been trying to push this advocacy boulder up the hill. Mm-hmm. And trying to have pain be taken seriously. And sometimes it's like making these strategic decisions about, like, we're not going to talk about the stuff that we think could jeopardize pain being taken seriously, even though there's all kinds of evidence around social prescribing, like prescribing nature, prescribing art-based therapies, peer support, these things. And I think, as we get pain reaching that tipping point, now is the time to kind of take the lid off and say, there are all these other things that, had we started with those, we may have been laughed out of the room a little bit, quite frankly. And these are always the decisions about, like, what's going to help us move the agenda, even when we understand pain. I mean, going back, we didn't say pain is a biopsychosocial spiritual issue. We said it's a biopsychosocial issue. Mm-hmm. But we know that the spiritual component is so big for so many people. So always this thing about, like, how do we stay true to ourselves? How do we stay true to the agenda? And how do we also, like, get the boulder up the hill, and then bring in all these other pieces? I don't know, it's just one idea, but we are really keen on the social prescribing, the art-based, narrative medicine, and those things I think are going to come. Keith?
Fabulous, thank you. Keith?
Thank you. Just to pick up on what Maria said, again, I believe these are hugely important areas of self-management, supportive self-management, living better with pain that we need to look at. And as Maria said, up until now, there's been a challenge with trying to introduce some things because, and again, I go back to my experience, which was a long time ago, it's all in your head. That still happens to people like this minute. There's somebody in Canada right now being told by a healthcare provider, your pain isn't real and you're just drug seeking. So I agree with Maria, there has to be a bit of, there's that balance to try and move into these other areas of pain management and living better with pain. And I would suggest, and I'm going to take this opportunity to get on my soapbox, I have one of many, that it's that totality of the impact of people's lives. And one of the areas I believe that we as a society and need to focus in on is educating healthcare providers when they're in medical school about what pain is. In Canada, some schools teach 8 hours. Some might give you 24. We've all heard the stories about veterinarians that get more education in pain for animals than doctors and clinicians and nurses and NPs and all of that for human beings. So fundamentally, we need to, as part of our grassroots, get it established, is to get education at the education level. First year medical schools talk about what pain is. They're very good at talking about how to remove my spleen and set my broken arm. Terrible, sorry, it's a little bit strong, but rather terrible in how to deal with somebody who has chronic pain disease. So I'm not saying we abandon or we don't look at these other opportunities. We absolutely do. But I do feel that we really need to properly educate those that are there to help support and manage those living with pain better.
Fabulous, and such a great point. And I can say that I'm aware that the Association of Faculties of Medicine is in Canada is actually actively looking into helping to level that playing field. More on that. I know that we could have spent another hour on this discussion. We have about a minute left to with one final question. So apologies to anyone's questions or comments that we didn't get back to. But if I could ask for a quick response, if it's possible, on has the progress of the national pain strategy been affected by the pandemic? If so, how significant of an impact has there been? We could just take a few moments, just a quick moment on that, if it's possible.
I'd actually say it's been accelerated, and I'd say that almost not in a good way. Okay, insofar as the challenges that people living with pain have been experiencing for decades and decades and decades, more people experience them now.
Mm-hmm.
That's what happened. That's what happened in the pandemic. People stopped having access to surgeries. People stopped having access to their primary care physicians. People started staying at home and didn't have as much access to physiotherapy and massage and chiro and all these other things that usually keep people functional and moving. And as a result of that, the voices got amplified. And the challenges of a broken healthcare system got amplified. The challenges that we were seeing in certain pockets are universal now. You know, for us here in Quebec and Ontario, we've had emergency departments just closed for days because there are not enough healthcare workers. Access to primary care physicians were amplified. If I can speak, I mean, this is not my role, but I had a cantaloupe-sized tumor in my abdomen. And the prognosis I got from my surgeon was that he could probably operate on me in 2026. And I was like, but it's like this big and I'm in constant pain. And like, what do you mean? It's like this big, like, you're gonna wait till it gets to be a basketball before we like take it out? And they're like, well, that's not a cancer. So we haven't even operated on those with cancer yet. And if not for JF and Maria and all the other people about telling me how to advocate for myself, I found a hospital 10.5 hours from my house and they could see me in 3 months. That's what the pandemic did. It amplified and had more people's voices have the exact same experience that you all have been having for decades. So it brought the attention right to the forefront. So did the pandemic slow things down? No, it accelerated. Yeah.
Thank you. What an incredible insight, and I'm glad you were able to find a solution. Listen, folks, I realize we're a little bit over time here, but it's hard for it not to keep going. I want to thank each and every one of our panelists today, Linda Wilhelm, Keith Meldrum, Jennifer Novak, Jean-Francois Leroux, Maria Hudspith, for your profound knowledge and experience and sharing of these incredible, around these incredible times and of the amazing work that each one of you is doing. Can't tell you how much we appreciate that. So thank you for your time so much. And I'd also like to invite everyone, we're about to take a 1-hour break. In fact, we're a little bit into it. So my apologies for that. We are offering optional guided movement session. All you have to do is go into your session or the exhibits area. We're also offering water cooler chats. Please participate if you feel up to it. We would love to have you there, and we'll see you back for our next session with Sick Boys at 4 o'clock Eastern. And was there anything else to add, everyone? No, we're good. Thank you so much.
Thank you.